Jayendra. I did my DMP orthopedics from Apollo Hospital, Chennai, and later my arthroscopy fellowship from Pakvan Hospital under Dr. David Rajan. Now I am working for Muthu's Hospital, Coimbatore. So today I will be presenting about complications in arthroscopic ACL reconstruction. So, even though I prepared for post-operative complications for ACL reconstruction, I will be talking a little bit about the pre-operative and intraoperative and how to prevent it. So the most common causes for pre-operative complications like for ACL reconstruction is mainly misdiagnosis, that improper clinical examination, like we are not doing a varus valgus stress, or like missing out MCL injuries, posterolateral corner injuries, and we are doing an ACL reconstruction coming out, there's a more chance of failure. And in our institute, how we were trained is, whenever we do an ACL reconstruction, we do all the examinations including varus valgus, dial test, and then proceed for the ACL reconstruction. And we do always do a pivot shift before, after anesthesia, and depending on that we plan for the ACL reconstruction. If the pivot shift is grade 3, we always plan for the ACL reconstruction along with addressing the anterolateral ligament also. And then other complications, preoperative complications, like we should be always prepared for addressing the ramp lesion, because when there is a ramp lesion and pivot shift grade 3 is there, if we address the ramp lesion, we don't have to do an ALL reconstruction. That will prevent an ACL failure, graft failure. And in MRI, in 3 out of 10 MRIs, the meniscus tears are missed, and most commonly the lateral meniscus. So we should always probe properly and look for the lateral meniscus whether there is any tear. We should not solely depend upon the MRI. And other intraoperative complications include like improper viewing the meniscus and inadequate fixation, then improper tunnel placement, and improper preparation of the graft. All these can lead to graft failure. And so coming to the post-operative complications, the most common complication is infection. The other complications are loss of motion, graft donor site morbidity, hardware related, persistent laxity even after ACL reconstruction, and venous thromboembolism. Infection, anyhow, it is very less commonly seen in arthroscopic surgeries because of the minimally invasive technique. And if we take the incidence, the early infection is when it is less than 2 weeks, and late infections is seen after 4 weeks. And mostly the superficial infections are 0.94% and deep infection is 0.2%. The risk factors mainly include male patients who have uncontrolled diabetes, prolonged surgical time, and hamstring graft are shown to be having more number of infection than bone patella bone, and in morbid obese patients and patients using tobacco and on chronic steroid use. The clinical features for infection mainly include fever, erythema, effusion, loss of motion, and discharge. When suspecting an infection, the clinical examination is very important, and usually patients present with fever and loss of motion and pain with some effusion in the knee. When we are suspecting an infection, we always look for the total count, ESR, and CRP. And when in doubt, or when we are not sure whether it is an infection or some other cause, we always aspirate and send it for the cytology. And if the polymorphs are more than 90% or if it's a purulent or culture positive, we proceed with an arthroscopic debridement. So in most of the cases, just with an arthroscopic washout, we will be able to tide over the infection. We always don't remove the graft immediately. If the tension is good and the fixation sites are good, we always try to retain the graft. But if the infection doesn't settle in 3 to 4 weeks time, then we plan for the removal of the hardwares and the graft, and we plan for a revision later. And in this study, they had tried vancomycin soakage of the graft, and this has helped to control the infection rate to a very less extent. So in our institute also we are currently using vancomycin. Once we harvest the graft, we take 500 mg vancomycin, mix it in 10 ml of the water, and we put it in a gauze and soak it around the graft and keep it after tensioning till we pass the graft. That may be approximately 5 to 10 minutes. And this has shown to reduce the infection rate drastically. So the others are like the surgical site infections where once we get the culture, we take the culture when we do the debridement, and once we get the culture report, we start on antibiotics that are sensitive to the organisms. And we always do an arthroscopic synovectomy, and along with that we also take the synovium which is present over the graft. That is also very important to control the infection. And graft preservation is almost always tried as much as possible. Only after 3 or 4 debridements, if the infection is not controlled, we take off the graft. If CRP does not reduce by 72 hours, we do a repeat arthroscopy. And the antibiotics, consultation antibiotics are given for a period of 6 weeks. If it is a purulent infection with heavy growth, IV antibiotics may be given for 6 weeks, or else for 2 to 3 weeks of IV antibiotics, and once the infection is controlled, we switch on to oral antibiotics. And it is always better to prevent the infection than to treat infection. So while selecting patients, we always avoid them to cease tobacco use, and once the HbA1c level is controlled, and then we plan for elective surgeries. And prophylactic IV antibiotics are given just before or during the induction of the anesthesia, but we don't know the efficacy. But this vancomycin is okay, just help us to drastically reduce the infection rate. And the patellar tendon graft, if possible, can be used. The number of ACLs we operate on a day should be according to the number of ACL trays available. And other post-operative complications like the loss of motion, where there is an arthrofibrosis, where arthrofibrosis is a diagnosis of exclusion, and most of the cases it will be taken over by physiotherapy, and in extensive cases an arthroscopic arthrolysis can be done. Most common causes of loss of motion could be graft impingement. If the graft is placed too posteriorly the tibial side, it can impinge on the PCL and cause reduction in flexion and pain. If the graft is placed too anteriorly, then again it can cause extension, loss of extension, and may require revision. Then improper tensioning can lead to persistent laxity or graft failure, and that can also lead to reduced loss of motion and cyclops formation. The previous concepts were like the ACL surgeries were delayed for a longer period, like till we get a good range of motion and the effusion all settles, in order to avoid arthrofibrosis and cyclops formation. But that concept is gone now. Nobody waits for ACL reconstruction. It can be done as early as first day or second day after injury, and that has shown even better results, like the better range of motion than delaying ACL reconstruction. And the other complications that is related to delaying ACL reconstruction is like it can lead to a meniscal injury, or where there is a repairable meniscal injury, it can become a more complex tear, which is more technically difficult, or can be even irreparable tear. So in this study they have shown that the cyclops lesion of the knee, and they have shown that there is an incidence increase from 25% at 6 months after ACL to 33% by the end of 1 to 2 years. Only 2 to 10% of cyclops lesions were symptomatic. So this study is also suggestive of that the cyclops formation is very less, and we can do ACL reconstruction at the earliest. We don't have to wait. And based on the location, the tibial site is the most common form where the cyclops formation is there, and it is usually an asymptomatic cyclops lesion. In the mid substance, it can be symptomatic. The risk factors for a cyclops lesion include female sex because of narrow notch, increased volume of graft in relation to the notch size. We always look for the notch, and when there is a narrow notch, and females usually have a narrow notch, we should not hesitate to do a notchplasty when there is a narrow notch. This can lead to graft failure. And bony avulsion of the anterior cruciate ligament from the tibia. That's also a complication of the cyclops lesion. And anterior tunnel placement of the tibial tunnel, and double bundle ACL reconstruction because of the higher volume of the graft, and the bicruciate retaining arthroplasty of ACL injury or sharp tibial bone accident, and hamstring contracture. MRI has sensitivity and specificity and accuracy of 85% for the diagnosis of cyclops formation. There was good results after excision of the lesion done within 12 weeks of presentation. For prevention, the recommended strategies for preventing cyclops lesion include the following: delaying ACL reconstruction until after recovery of ROM, minimally invasive surgery compared with open ACLR, creating less debris by the use of sequential reaming and thorough removal of debris, correct tunnel placement, debridement in and around the bone tunnel, trial extension with the reamer or drill placed through the tibial tunnel to check whether it impinges with the notch, and notchplasty if associated with impingement of the ACL graft, and if possible, drawing the graft from the femoral tunnel first into the tibial tunnel to draw debris into the tibial tunnel, and early post-operative mobilization. All these allows to prevent cyclops formation. And when graft impingement is there, the most common cause could be a tunnel malposition, which is too anterior, or when there is a double bundle reconstruction, that is also a bulky graft and it can cause graft impingement. So arthrofibrosis is seen in up to 5% of cases, and in this study they have found that the risk factor is when the age is less than 18 years in female patients, or when there is a post-operative hematoma, and when using bone patellar tendon or quadriceps tendon, and when associated with the meniscal repair. The loss of flexion is better tolerated than loss of extension, because extension deficit alters the gait and increases the load on patellofemoral joint and medial joint. Surgery in a quiet knee always reduces the chances of arthrofibrosis and also the loss of range of motion. Around 80% compared with the contralateral side is the pre-operative requirement for ACL reconstruction. If we want to avoid cyclops formation and better range of motion. So when there is a cyclops formation, do early rehabilitation, early ROM, and brace in extension. So the other forms of treating loss of flexion deficit include like a drop-arm cast, where the anterior thigh is pushed down so that we can get a good extension, and manipulation under anesthesia, arthroscopic isolysis, arthrotomy. Surgery is beneficial if done within 8 months. Oral steroids for loss of flexion has shown some improvement in flexion with physio. The impact of the surgical time on the outcome of anterior cruciate ligament reconstruction. In this study, they have found that early less than 48 hours ACLR has significantly fewer patients with an extension deficit. There is no difference in cyclops removal or repair. So this study also suggests that ACL reconstruction can be done at the earliest, even after first or second day of the injury. And in this study, they have found that there is a better functional outcome in patients like better ROM, IDC, and Tegner score when the 6 months post-operatively, and at 1 year follow-up, both delayed and early surgeries, both of them where both the groups were comparable results. Then donor site morbidity is another complication which is seen. It is like a sensory deficit in the anterolateral portion. It is most commonly because of the graft harvesting technique, and by doing a blunt dissection we can somewhat try to avoid this complication. But once this has developed, the nerve is not going to regenerate, but the other nerves surrounding the structures can supply that area and cause and reduce the symptoms by 8 to 9 months. And anterior knee pain is seen with patellar tendon harvest, and And with patients having patella vaga or already having chondromalacia patella, the patella tendon should not be harvested. If we are doing harvesting a patella in a patella vaga patient, then the graft length may not be sufficient. And the scar and keloid formation. So this was the thing I was explaining, where there can be an injury to the intrapatellar branch of the saphenous nerve. So oblique incisions have better results than vertical incisions, but this can be always managed with the pregabalin and nortriptyline, and the patients tolerate well. In this meta-analysis of bone patella tendon bone autograft, they found that anterior knee pain was more common in bone patella tendon bone graft. There is no difference in anterior pain on long-term follow-up like for 2 years, and it is a minimally invasive technique, and the incidence of sensory disturbance is very less with bone patella tendon bone graft. Then hardware-related complications like intra-articular placement of the hardware, this can again lead to loss of knee extension and later screw migration or late migration of the interference screw. And this is an example where the screw has come into the joint and led to loss of extension. So this will definitely require removal of the implant and revision. Then related to the implant, persistent discharge at the tibial site, like some studies have shown that the PLLA screws has led to cyst formation and led to tunnel dilatation and discharge, and maybe like loosening of the implant. So that can be avoided by using a pinch screw or a titanium screw. Then persistent laxity due to poor fixation technique, or like a missed collateral injury. When an MCL or MCL injury is missed, that can be lead to persistent laxity and failure to the ACL graft. Then the frank instability or failure to return to sports, and ACL return and kinesophobia are seen with persistent laxity. Then identifying and treating ACLR. In contact and promoting sports and with a significant meniscus deficiency, ACL reconstruction should be done early. And the rates of deep vein thrombosis is comparatively very less in ACL reconstruction. And when in doubt, we should, and it can be seen when there is a prolonged surgery with the long tourniquet use, in tobacco use, and when it is associated with a concomitant osteotomy. So in osteotomy patients, a DVT prophylaxis like a Clexane or 10A inhibitors can be used, with which the incidence of DVT reduces. And when in doubt, we always get a vascular surgeon opinion. And in routine thromboprophylaxis is not recommended for isolated ligament reconstruction procedures. And mitigation of risk factors like reducing the surgical time, and when the surgical time is more than 2 hours, deflating the tourniquet for some time, and for like 15 minutes or 20 minutes, and then again deflating and proceeding, helps to reduce the risk of thromboembolism. If symptomatic, we always get a vascular consultation. Thank you.
Thank you.